welcome everyone to RTI International's COVID-19 webinar series. We're very glad you could join us today. I'm Dr. Lauren McCormick, Vice President of the Public Health Research Division, and I'll be kicking off the webinar today. As you can see, it's on social distancing. You can go to the next slide, Shane, please. And face coverings, and I'll also be introducing our speakers. But before we do that, I'd like to tell you a little bit about the webinar series that we have scheduled for the month of May. So we have 4 sessions on different topics, starting today, again, with face coverings and social distancing. And the data come from 2 RTI-funded surveys that we did of the American public. As I mentioned, today's topic is social distancing. Next week is the public's understanding of COVID-19. In particular, we're going to be looking at that in that session about how knowledge and understanding changes over time since the early days in the pandemic. On the 3rd week, we'll be looking at perceptions of risk and threat from people's perspective about the virus. And on the last session on May 27th, we'll be looking at vaccines, including people's intentions and behaviors related to the vaccine should that become available. So we're really hoping that you can join us for all of these sessions. Okay. The next slide ahead. Thank you so much. So the findings we're presenting today come from the 2nd wave of the survey, which was conducted in mid-April. We conducted a 1st wave at the very end of February and beginning of March. And this was at a point in time when it was relatively early on in the pandemic, before there was more media attention on the topic. And it was around the same time when there was the first death in the US. As you can see here, the surveys collected information about perceived risk, knowledge, attitudes, beliefs, and behaviors related to COVID-19. And in the middle there is some of the information we're going to be touching on in today's webinar. We also asked a series of open-ended questions, which I'm not going to read these to you, but you can see them here. And they have provided some very rich and qualitative information that we are going to be interspersing into the presentations and webinars, along with the results from the closed-ended questions. And these focused on people's information needs and challenges that they're having with respect to COVID. All right, so we're very fortunate to have an interdisciplinary team across RTI working on a wide range of COVID issues, including the work that you'll hear about today. And I would just like to acknowledge the full survey team that's behind this effort. And representing that team, you'll hear from 3 speakers today. The first is Dr. Linda Squires, and I'd like to introduce each of them briefly to you. Dr. Squires is a senior health communication scientist in RTI's Public Health Research Division and has worked in public health for 30 years. Her research focuses on conducting rapid assessments to gauge how the American public responds to high-profile public health issues. She also plans, implements, and evaluates large public health campaigns and led an RTI project funded by the CDC to develop its Clear Communication Index. Next, we have Dr. Christine Bevick. She's a research analyst in RTI's Public Health Research Division with 16 years of experience. And her areas of expertise include public health systems and services, emergency preparedness, response and recovery, and at-risk populations. Her research has appeared in multiple peer-reviewed publications. And then finally, we'll have Ms. Alicia Frasier. She's a senior survey director within RTI Survey Research Division, and is an expert in the execution of an extensive range of survey research and methods. In her 17 years of experience, she's worked across a broad range of research topics and respondent types, including children and patients. So we are going to leave a little bit of time at the end of our session for questions. Dr. Squires will serve as our moderator for that portion, and we will be sharing the slides with presenters. We'll email them out after the session. So with that, I'm going to turn it over to today's presenters. Thank you.
Thanks, Lauren. So today's presentation does focus on social distancing and cloth face coverings. We ask questions to delve into what does the general public know and believe about face masks, cloth face coverings, social distancing, and stay-at-home policies and practices, who is adhering to these mitigation strategies, and what are some of the challenges or barriers for adhering to the required or suggested behaviors. We will discuss the question of how can we support social distancing moving forward. For this data collection, we used Ipsos's Knowledge Panel, a probability-based internet panel designed to be representative of the youth households. This panel uses an address-based sampling approach to recruit and maintain the panel. RTI developed the survey instrument and conducted the analysis of the resulting data. We collected data from approximately 2,300 respondents. The survey was fielded for this wave, April 10th through 13th and 17th through 20th this year, and the survey data were weighted to represent the US population. On this slide, you can see the basic demographics of our respondents, weighted to represent the characteristics of the general population, including gender, age, race, and ethnicity.
Thanks, Alicia. So next, we want to show the compiled timeline to provide a context of when these data were collected and to remind us of all what was happening when. And there is a lot going on the slide, but that's because there's been a lot going on in the United States related to this virus. Breaking it down, the blue bars show the wave of states declaring a state of emergency. The green bars follow, showing the number of states that declared stay-at-home orders. And the red bars reflect the recent issuance of state and local face covering requirements through the end of April. Below the chart, we call out several key dates showing when the national emergency was declared by the White House on March 13th, followed by CDC releasing recommendations for social distancing on March 30th, and face covering recommendations on April 3rd. The tall green bars on the chart that you see represent when RTI collected data. You can see that our first wave of data collection occurred at the beginning of the state level response. And this period aligns with the first reported COVID death in Washington state. Our second data collection period took place after CDC had issued recommendations for social distancing and face coverings. And today, as Alicia mentioned, we'll be sharing results that are primarily from our second wave. So the data reflect what individuals are thinking, feeling, and doing 1 to 2 weeks following the issuance of face covering requirements or recommendations. Next slide. Great, thank you. In the big picture, when we asked about the agreement of social distancing policies, generally respondents agreed at a pretty high level with these policies. 82% indicated that they believed that more people would die from coronavirus if schools, businesses, and the public places opened up too soon. 87% supported strategies that were put in place in their states to mitigate the spread of coronavirus. And 90% indicated that everyone needs to follow the strategies put in place in order for them to be effective. We also saw that, however, that 23 of respondents indicated that they would rather risk getting the virus than losing their jobs. And as state orders begin to lift and efforts to reopen move forward this week, many of the approaches rely on social distancing and face coverings to prevent new outbreaks. Overall, related to this, most of our respondents, 69%, recognize that social distancing has been successful in prior disease outbreaks. However, there's room for improvement in these results. 1/4 of the individuals surveyed did not know if these strategies had been successful. When we asked respondents if they agreed or disagreed with a set of statements about social distancing, we again see a high percentage of respondents agreeing. When we asked this question in early April, most respondents felt confident that they could shelter in place. They were also confident, with 75% reporting in the affirmative, that they had all the information they needed to protect themselves. As concerns for the burden on our healthcare systems continues, we also asked about individuals' abilities to manage the illness at home if they or a household member were to become infected. Social distancing then within the household, if necessary, is not without its own challenges. Among those surveyed, there were low levels of concern and perceived resistance reported. In a series of closed-ended questions, we asked particularly about whether they encountered challenges when it comes to staying at home, distancing, or thinking that the rules don't apply to them. And overall, if we were to create a report card of social distancing behaviors, we'd find social distancing and sheltering in place scored highly with our respondents. Individuals are largely avoiding those non-essential activities and staying home. And as we look down the list, face coverings are another key strategy in preventing the spread of COVID-19. At the time of our survey, right around when CDC released its recommendations, we see that about half of our respondents reported wearing face masks in one form or another. Despite the high percentage that shared an intent to wear a mask, 50% wearing, but 75% intending to wear a mask. Alicia is going to be focusing a little bit more closely on face coverings in the next segment here. So as we reflect on these promising findings, with all the activities and the changes in the past 2 months, we cannot overlook or discount the accompanying challenges associated with these strategies, particularly as they relate to mental and social health. In our open-ended questions, about 20% of our participants reported substantial challenges related to mental health, ranging from feeling bored or lonely or stir crazy to becoming severely depressed due to isolation from social distancing. Many described missing their family members and friends, and some described the stress of juggling childcare with working from home. While a majority report a willingness to comply with stay-at-home requests and social distancing orders, there is an undercurrent of frustration with non-compliance of others. Our respondents commonly expressed frustration about others, including family members not taking the guidance seriously, not maintaining a 6-foot distance at the grocery store or outside, or leaving the home for non-essential reasons. Some participants said this lack of compliance in the community made them feel less safe. And this theme resonated particularly among our Spanish-speaking respondents who frequently cited this challenge. Next, I'm going to turn things back over to Alicia Frasier as we focus on another community mitigation strategy.
Thanks, Christine. So now we'll dive a little deeper into the data we collected specifically on face coverings. Shane, can you go to the next slide, please? Next one, please. All right, and next. So a majority of respondents, 77%, indicated correctly that wearing a cloth face covering may prevent one from spreading the coronavirus to others. 94% of respondents correctly indicated that wearing a cloth face covering does not mean one does not have to worry about social distancing behaviors. This is encouraging that respondents understood these facts about face coverings at a time when the recommendation was only just being given by the federal government. In addition, 75% correctly indicated that wearing a surgical mask will help prevent spreading the virus to others. Since cloth face coverings and not surgical masks are what are recommended to the public to wear, we focused on asking questions about cloth face coverings in the survey and in our presentation today. We asked a series of questions about the perceived effectiveness of the 4 social distancing activities and behaviors listed on the screen here, including wearing face coverings, closing schools and businesses, staying at home, and staying 6 feet apart. And we asked about those in relation to the respondents' perceived effectiveness of these behaviors in reducing deaths, protecting people in the community, and protecting the respondents and their families. As you can see, respondents indicated high perceived effectiveness for closing, staying at home, and staying 6 feet apart, all in the 80% range. Interestingly, face coverings were perceived as less effective than those other measures, and those showed in the 60% range. Very interestingly, even though the recommendation for face coverings is not driven by the protection it provides the wearer, but rather the protection it provides from spreading germs to others, 64% of respondents indicated agreement with the statement that cloth face coverings protect themselves from getting coronavirus from others. This suggests respondents may be driven more strongly by motivators of self-protection. In developing public health messaging, altruistic communications about face coverings may leverage these drivers. In response to the statement, Everyone, including people who do not have symptoms, should wear a cloth face covering if they leave their home to prevent possible transmission of the coronavirus. 82% agreed with this statement. This indicates that the public likely perceives wearing a cloth face covering as a new norm now. Looking at the difference between current behavior and indicated intended behavior, we found that about 51% of respondents indicated they were currently wearing face coverings and 46% were wearing medical or surgical masks. This was a little surprising given that the recommendation had been made at the beginning of April for everyone in the country to be wearing face coverings while out in public. And we were asking this question of our respondents the second and third weekend of April. Very interesting, however, this was a 40 percentage point increase from when we asked this question in our first wave of data collection the very beginning of March. So that is encouraging. In addition, asking about intention to wear cloth face coverings in public, we found that 77% of respondents indicated they plan to wear a cloth face covering in public settings. Obviously, this is higher than those indicating that they currently were wearing face coverings. To dig into these findings a little further, we looked at the questions we asked about potential barriers to use of cloth face coverings. When looking at stigma, the statement, "I worry that if I wear a cloth face covering out in public, other people will think I am infected with the coronavirus." Interestingly, 85% of respondents indicated disagreement with this statement, leading one to believe that most of the public is not worried about being stigmatized for wearing a cloth face covering. When asked about making a cloth face covering at home, 66% indicated that they knew how to make one at home. That's a good percentage of the public, but it does leave about 33% who indicated not knowing how to make one. The difficulty to make or obtain face masks or coverings was evident in several of the responses we received to the open-ended questions we asked. One of which is, what is the biggest challenge you are facing when trying to follow the strategies in your community to try to slow down transmission of the coronavirus? This respondent said, people are walking around with face masks, but where are they getting them? We also saw themes related to ability or self-efficacy of wearing a mask in the open-ended answers. A respondent said, I sometimes have difficulty breathing due to MS. The mask covering my nose and mouth constricts my breathing. I don't like wearing the mask in public. And although exacerbated by a health condition, this highlights the difficulty of wearing a mask for periods of time and communicating while out in the public while wearing a mask or face covering. I would assume many of you on the webinar today have recently felt that wearing a face covering is challenging in your activities outside of your house. I have definitely found that to be true over the last few weeks as well. And now I'm going to turn it over to Linda.
Hi, everyone. So we've provided a snapshot of what Americans know, believe, and are doing related to social distancing and face coverings in mid-April under lockdown conditions. We found that the public's highly supportive of social distancing policies to keep the public safe. And we've seen a dramatic increase in the proportion of people reporting using a face mask or covering over time. And we have many states that are reopening now, and that really signals back to normal. Yet this article on the screen here shows and says, we're not going back to normal. So we need to really conceptualize and operationalize what does this new normal look like in terms of social distancing. Dr. Deborah Birx, one of the White House's top coronavirus task force officials, has indicated that social distancing will be with us through the summer, but each state may implement these social distancing strategies differently, and adjustments may be made along the way. A week ago Monday, the governor of Ohio said, no masks, no work, no service, no exception. However, in response to an outcry from Ohioans, he rescinded the statewide order the following day, saying that a statewide order mandated people wearing face masks to prevent the future spread of the coronavirus had gone too far. So under lockdown, people were supportive and mostly compliant. We are now asking the public to adopt new behaviors and make them habitual. When creating a new normal, what we're doing is creating new social norms. And for people to embrace them and consistently practice them, they need to know how to do it, why to do it, see others do it, and believe that these different behaviors are going to be effective. In terms of knowing how to do it, 25% of our samples said they do not have the information they need to protect themselves and their family from being infected. So that is our next webinar focuses on knowledge. So I'm not going to delve too deeply into the knowledge gaps today. We'll take a look at that next week. But what I can share is that we can use our data to help develop strategies to segment audiences into groups and identify who says they don't have the information that they need. So, we can use our data to help really dig down and figure out who has the information gaps and strategies for reaching those different groups. Social distancing self-efficacy is someone's perceived ability to practice social distancing behaviors like wearing a face mask or keeping those outside of the household out of the home. In our initial multivariate models, we're seeing that self-efficacy is related to behaviors. So the higher the self-efficacy, the more likely it is that people are practicing the behavior. So not only do we need to equip people with the facts about social distancing and how to do it, we need to take a deeper look at what's affecting their belief that they can do so. So we've identified barriers, and using our data, we can further explore these and develop with specific groups who are experiencing low self-efficacy strategies to overcome these barriers. We need to make sure that we're using clear communication principles when developing communications. So RTI, along with Communicate Health, helped CDC develop this clear communication index. And this is a research-based tool to help you develop plain language public health communication materials. And this is publicly available on CDC's website. Next, we also found that almost 40% of respondents agreed or strongly agreed with the statement, what I do on a day-to-day basis will not affect how many people in my community get the coronavirus. Tara Smith, an epidemiologist at Kent State University, has said that the benefits of social distancing are largely invisible while they're occurring because there's no clear indication when a coronavirus case or death is avoided. It's the paradox of public health. When you do it right, nothing happens. So we need to find ways to communicate this clearly and strategies for ensuring that people understand that what they do does in fact impact transmission rates. We also might look at how social distancing is being framed. Allen and colleagues just published an article in Health Affairs suggesting that we stop using the term social distancing and start talking about physical distancing and social connection. Using the term social distancing, they say, reinforces the idea that these directives encourage both physical and social separation, which is clearly not their aim. I share this to point out that how we frame new behaviors can greatly impact their adoption. So new message frames, such as the one proposed in the article, really need to be tested and can be done so both systematically and quickly using surveys such as the one that we just conducted or other qualitative research methods. We're able to conduct this kind of rapid testing of message frames and messages, just as in this example. So it's important that as we move ahead, we gather evidence that the messages and message frames will be understood and get early evidence that their use may lead to wider adoption of social distancing behaviors. And if social distancing is here to stay, we also need to keep people motivated to keep practicing these behaviors. Let's face it, their behaviors, they're challenging to say the least. We're already weary and we would all prefer life to go back to normal. And the outcomes of social distancing or lack thereof, they won't be realized for several weeks. So again, we're not getting an immediate reward for these social distancing behaviors. We asked respondents what their main motivation was to follow the strategies in their state or community to try to slow down the transmission of the coronavirus. And this is an open-ended question. We got almost half of our respondents providing an answer to this question. And of that half, we had about a third of respondents citing their own health concerns and personal safety as their primary motivation to follow community mitigation strategies. And they cited concerns such as being a senior, being at higher risk due to pre-existing medical conditions, and simply not wanting to become infected. About another third of those who responded to this question said they were motivated due to their desire to protect friends, family, and loved ones. And then another third of respondents shared motivations that focused on the broader community, state, and country, including flattening the curve, preventing deaths, and slowing and stopping the spread of the coronavirus. So I share this because different groups and different individuals are going to have different motivations for trying to sustain these behaviors over time. And so to ensure that the public does stay motivated, we need to keep the why social distancing is important front and center in our messaging and our strategies. And we need to develop and test motivational strategies to see what works now and what works in the future. We'll need to provide cues and reminders for people to remember why social distancing remains important. Who are they doing it for? With a number of deaths now over 70,000, we can drown in a sea of numbers. We need to find ways to keep each person's personal motivation up front. That's my mom there on the little button that we created. That's who I do my social distancing for. And it's a good reminder. I'm hoping to truly create this and wear it when I go out. And so then if people aren't motivated to protect themselves, or they don't have a person in their life like my mom that they were trying to prevent, then we can frame social distancing as a way to socially connect and socially respect and care for each other, and really capitalize on self-altruism. Practicing social distancing is a way to do good for others. Doing good makes us feel good and positively reinforces these behaviors. We need to use what we know from behavioral science to develop messaging and strategies that work. So maintaining this motivation over time will be challenging, and we need a multi-pronged, multi-layered approach that adapts over time. And again, we need environmental cues and positive reinforcement. We're asking people to practice new behaviors. So the behaviors need to get modeled, and we need to create these positive rewards that people get immediately. The 3 weeks later, we know the curve is flattening is not great motivation for a behavior you're asking them to do today. So, we've got to think creatively, and we can crowdsource ideas how businesses and communities can reward individuals and groups for continuing to practice the social distancing behaviors and provide visual and auditory cues. So we need to test and evaluate the strategies over time. States, communities, organizations, and businesses will all be trying different strategies. What we have in front of us is a huge opportunity to learn what's working and what's not. In many ways, we can take advantage of these natural experiments where implementation and messaging strategies to promote social distancing will differ. But we need to start these types of assessments and evaluations now within organizations and businesses, and within and across states and nationally. We're developing a multi-level evaluation framework to assess these social distancing policies and strategies and their impact. As we create the new normal that includes social distancing, we need to have an evaluation mindset so that we can learn together what strategies and messages work, under what conditions, over time. So we are very eager for your questions and ideas. I see lots coming in. And we're going to transition and take some questions at this point. So we've had several questions about the demographic specific findings. For example, age, race, ethnicity, and whether or not we can speak to these findings for different subgroups. So if you, Shane, you could go back to the slide early on that showed the demographics, and I'm opening this up to all of our speakers. I know we whipped through that pretty quickly, but this is a nationally representative sample And it's I think one or two more back right there. So these are the demographic characteristics. So it's a sample of over 2,000, and the sample has been weighted using the American Community Survey to represent demographically the United States, the population of the United States. So we have pretty robust sample sizes to delve into some of these subgroups. We have lots more than just these demographic characteristics, and we're starting our analyses looking at behaviors and knowledge differences by different groups. So beyond just the demographic groups, we've also segmented the states by early adoption of social distancing, late adoption, and then no mandates at all. We've got characteristics of our sample of do they know somebody, or have they themselves been infected with the coronavirus, or has someone in their household. We've also got demographic characteristics, of people if they have a chronic disease that would have put them at risk for coronavirus, or if someone in their household does as well.
And Linda, it's Alicia. I'll jump in here as well. We've seen some questions about, dissecting some of these findings by some of these demographics. And one that we have looked at just briefly is the intention to wear face coverings by different demographics, excuse me. And we do have that one. We do know that females drove that response at about 82% indicating they plan to, whereas males said 72% plan to, 72% plan to. That was significantly different, statistically different. Age range, we saw some differences there. Interestingly, we saw some in the Hispanic origin. Hispanics indicated 84% indicated plan to wear face covering, and non-Hispanics said that at 76%. And then we did see some differences by education. And I think, interestingly, for me, region was a big one, with the Northeast region population indicating at a higher level that they plan to wear face coverings.
Okay, thanks, Alicia. Okay, so another question is, do you think the large increase in people intending to wear face masks between the first and second survey is likely due to the change in the World Health Organization recommendations first against and then for the face masks? Yes, I think that huge increase clearly has to be attributed to both the World Health Organization and then the CDC recommendation. Given the timing of when we did our first wave and our second wave, that along with the lockdown, I think all those things coupled together, people are clearly understanding the need for the face coverings. There is some, I wouldn't say confusion, but as Alicia has shared, there's a difference in people's knowledge about the purpose of the face covering, whether it's due to its purpose is to protect you, if you're infected, you may not know it, from transmitting the virus to someone else, or if it's actually offering protection for you yourself. We have seen in some of the analysis that we're just starting to do that that belief that it's protecting you from others is really pretty influential in terms of the behaviors. Okay, was the only indicated stigma based on possibility of being perceived as someone who has been infected? We do have a set of questions on stigma that we are just beginning to analyze. So no, that was not the only stigma question. That was the only stigma question that was specifically related to wearing a face covering. And so we had some indications early on that people might be concerned that if they wore a face covering that they would be perceived as being infected, and if they weren't, then they didn't want to send that message out to others. So that's why we put the specific question on our survey about that, and we saw that I think it was 85%, if I'm not mistaken, did not have that concern. I think the messaging that has happened around face coverings has been positive in that it's not signaling, oh, if I'm wearing a face covering, I have coronavirus. And people were not, on the other stigma questions, there did not seem to be, so far, like a huge concern about people feeling like they would be stigmatized if they got coronavirus, that they would be blamed, shamed, that kind of thing. We'll delve into that. We may do another presentation on that in the future. We did not ask us, sorry, I need to read the question. Did any of the respondents indicate perceived risk of wearing face coverings as being mistaken for someone intended to commit a criminal act? We did not specifically ask that question, nor did we see that in any of the open-ended responses to questions. That's not to say that that belief does not exist. It's just not something that we picked up in our survey. Can we speak to the issue of voluntary compliance with guidelines, given that some Americans may opt to go to work even if they are sick to avoid lost wages? No, we don't have a specific question on that. We do have a question that assesses whether or not people, to get the exact wording, but it's, sorry, 1 second. I'd rather lose my job than get the coronavirus, something like that. Sorry. Let me come back to that one in just a second. I'll find that question.
Linda, we do have that one on a slide. We could pop that up. I'll find the slide and pop back in.
Thanks. Okay. Did any of the survey questions ask about sources of information and trust of those sources? We do have that information that we can couple with the questions that we asked. So that is part of the background information that we have for people in the panel of what were their sources of health information and trust in those sources. I don't think we have that, but we do have what the sources are. So we can be taking a look at the results by the different primary sources of information that they use.
And Linda, back to that last question, Shane, if you'll go to slide 10. We do have, 23% indicated that I would rather risk getting the coronavirus than lose my job. So that was one of the questions we did ask to approach that concept.
We have another question that's, did any of the measures ask people for their understanding of what social distancing is? We did not ask that. We did assume some level of knowledge about it and defined it within specific questions in different parts of the survey. Yeah, thanks. This is a good one to put up. We had household resistance to social distancing. So we have defined social distancing as a broad term that encompasses a lot of different behaviors. So getting people to stay at home and staying 6 feet apart. We have that behavioral report card question. So there's several behaviors under that particular slide that we could also point to. We also have a question about, did you probe for sources of resistance to stay-at-home orders or masks? We did ask an open-ended question about what were the main barriers to the different social distancing, to social distancing and face coverings.
And Linda, this is Lauren. I'll just jump in. I saw earlier that there was a question of whether the results were presented to the North Carolina DHHS office, and we have had an opportunity to present the first wave of results, but not the second wave. We'd be happy to help with that and set up a time to do that if that would be of interest, and to others who may need additional information.
We have several questions just about disseminating these slides. So I know we said at the top, and people may have joined late, we will be sending the slides out to anybody who has registered for the webinar today. We also, again, this is our first snapshot, trying to get results out, you know, some of the highlighted results and frequencies, and a little bit of a look at some of the bivariate comparisons. We are delving deeper into the data, and certainly are happy to share what we can. So if you have specific interests, then feel free to contact us. This is a self-funded study. So RTI is a nonprofit research organization. So we did use our own funds to fund both the first wave and the second wave. You know, we are interested in partnering with organizations who would like to continue, help us continue this research. Right now, you know, we've been focusing on making sure we're getting the national snapshot, but we certainly can pivot and design surveys like this to for evaluation purposes for specific states, smaller populations, harder to reach populations. You know, we're a very, very experienced company that does lots and lots of survey research and knows how to handle this pretty rapidly. So we have a rapid response research, survey research team for COVID. And we'd be happy to work with you if that's a need of yours. Okay, I'm gonna take maybe one more question, and I think we're going to close it up. So in terms of, we do have, okay, sorry, there's a lot of questions. Were there any questions that looked at the risk of face covering based on race? So we have started looking at some of those subgroups and certainly can share findings and hope to get those out in public forums as well. And
Linda, just to add to that, that is something that our qualitative team has been looking at. We did want to know about that in terms of the open-end responses, and then seeing if we were seeing any differences in terms of usage based on our quantitative information. And we were surprised that we weren't getting those kind of comments within the subgroup population. So within Blacks or Asians or any other lines along race and ethnicity. But it's something that our team is continuing to look into because we're very cognizant of the differences and the differential impact that this event is having on our population. I mean, it's really exposing some of those inequities that are ingrained within our country, unfortunately. And so I think that's that's one of the limitations we recognize, that with our panel, we're limited by the responses that we're able to have, the 12% that was called out. And in that moving forward, it's something that we're mindful of. Our second wave actually oversampled. We did an extra sample for the Hispanic and Spanish speaking population as well. So these are certainly key areas that we're looking at and continuing to bring into our results as we share them.
And again, we do have information from the respondents about whether or not they have had symptoms of the coronavirus, tried to get tested, received a positive test result or a negative test result, if they've been hospitalized, recovered from the coronavirus, and if someone in their household has. So, and then we actually also asked if they had a friend, coworker, or family member not living in the household that had symptoms, had tried to get tested, tested positive, negative, been hospitalized. So 25% of our sample either had symptoms themselves, someone in their household, or a friend or family member had symptoms. So what our intent is to look at that variable, like to look at all of our findings and create a proximity to coronavirus variables so that we can see what's the impact of knowing someone in these different states in terms of knowledge, attitudes, beliefs, and behaviors as well. So there's lots of different ways for us to use these data for you to partner with us to use these data in your planning and evaluations. And we are very pleased to follow up with you. So Shane, if you can go to the last slide. I want to make sure, and again, we're sending these slides out to each of you who've registered, so you'll have our contact information there. So this is my contact information, Dr. McCormack's contact information, and then there's one more slide, Shane. We also have lots of capabilities to support COVID responses at all different levels. So we do more than survey research. We have a center, we have a Center for Communication Science. We have a whole public health research division, but we have a deep bench of cross-functioning experts in all kinds of different areas, and we're happy to support you. So if you either email one of us that's on the slides here, that would be great. When you exit this webinar, you're actually going to be taken to our survey page, and there's a form on the survey page that you can fill out and put your contact information, and we'll follow up with you. Okay, so Dr. McCormack, I'm going to turn it back to you if you want to close this out.
Yeah, well, thank you very much, everyone, for being with us today. We really appreciate your presence, and we hope that you will be joining us in the future. We tried to get to a lot of the questions today, and we look forward to hearing from you for some conversations about partnering both domestically and internationally in this important area. So thank you again to our presenters and to our audience members. We're going to close it out now, and thank you very much